Penicillin group of antibiotics have a broad spectrum of coverage, including gram-positive, gram-negative, and anaerobes. The problem which happened with penicillin was development of resistance, mainly in the forms of beta-lactamase enzymes, which were called penicillinases, which could hydrolyze penicillin, and thus there was a need to discover newer agents, and this was done by side chain modification of penicillin. Ampicillin and amoxicillin are examples of this. They are aminopenicillins. They are active against many of the penicillinases, and more importantly, they are available orally. The first group of penicillin antibiotics to be available orally. At that point of time, ampicillin and amoxicillin restored the sensitivity of penicillin to Staphylococcus aureus. Staph aureus also elaborates beta lactamase, and these beta lactamases mainly hydrolyze a few group of antibiotics, and this was overcome by the aminopenicillins. Streptococcus pneumoniae and Haemophilus influenza also sensitivity was restored, and they had fair cover of the gram-negative organisms like Neisseria, E. coli, Proteus, Salmonella, and Shigella. The major problem which happened with the gram-negative bugs is the development of resistance, mainly by elaboration of beta-lactamases, such that they could hydrolyze ampicillin and amoxicillin, and that's where the cephalosporins came into picture. There are certain bugs for which the aminopenicillins are strict the drug of choice. They include Enterococci, Listeria, and Acinetobacter, which is carbapenem resistant. Ampicillin and sulbactam is a drug of choice for them. Ampicillin has a short half-life, as renal excretion has to be given more frequently, whereas amoxicillin has a longer half-life and better bioavailability, and it is partnered with clovolinate. Ampicillin has a partner in sulbactam, and this partnership was mainly done to overcome many of the beta-lactamases which destroyed ampicillin and amoxicillin. So ampicillin with sulbactam and amoxicillin with clovolinate may be considered something similar in spectrum to the cephalosporin, the third generation cephalosporins, and amoxiclav is also available as an oral agent. Historically, aminoglycosides have been added for synergy. They act on the protein pathways and these act on the cell wall, and this sequential involvement may have better results. We still use them for these indications, especially in infective endocarditis and in treatment of enterococcal infection. The antibiotic has a large therapeutic window, so we can use very high doses of ampicillin and sulbactam like we use for carbapenem resistant Acinetobacter baumannii, 12 grams and 6 grams. So you could be given something like a 4-hourly 2 grams of ampicillin and 1 gram of sulbactam. And as I said, the spectrum of the aminopenicillins with their beta-lactamase inhibitors is very similar to third generation cephalosporins. One of the problems with third generation cephalosporin use is the increasing emergence of ESBL strains, something which is not seen with aminopenicillins and with their beta-lactamase inhibitor partners. So that is why many places we want to replace the cephalosporins with a BL-BLI combination having an aminopenicillin, like in respiratory tract infections, and this is done as a part of the antibiotic stewardship program to decrease the incidence of ESBLs. Also, we will see re-emergence of certain strains which are resistant to newer antibiotics, and maybe these older generation antibiotics may show some activity against them. So we will be using ampicillin and amoxicillin in select indications, and maybe these indications broaden up with time.